Really sorry.
Good morning. This is a lecture on fracture of both bones leg. Both bones is nothing but the tibia and the fibula. The, the fractures of the both bones leg is being dealt detailed for an undergraduate student of MBBS. It is from the Sri Lakshminarayan Institute of Medical Sciences, Puducherry, which is affiliated under Bharat Institute of Higher Education and Research. I am Dr. Vijayaragavan, the Department of Orthopedics from Puducherry, Lakshminarayan Institute of Medical Sciences. We all know diaphyseal tibial fractures are the most common long bone fractures. What is the diaphyseal tibial fracture? Any long bone, we have the bone ends called the epiphysis. Okay, the shaft which gives the support, cortical support as the diaphysis. The place between the bone between the epiphysis and the diaphysis, we call it the metaphysis. Metaphysis is a cancellous area which has rich in blood supply. It gives the growth. Helps in the growth of the longitudinal growth of the bone. Okay. First, we will deal the diaphysis, that is the shaft. Diaphyseal tibial fractures. Diagnosis is confirmed by a plain radiograph of tibia and fibula with one joint above and one joint below. Clinically, we all know the signs of a fracture. Clinically, we have a swelling, bony abnormal mobility of a long bone, okay, crepitus, loss of transmitted mobility, okay. These are the signs of a fracture clinically. This is be confirmed by the plain radiogram. Okay. What is the incidence of a diaphyseal tibial fracture in a matter? Most common long bone fracture we are seeing day-to-day life. It make up about 17% of all lower limb, lower extremity fractures. It accounts for 4% of all fractures seen in Medicare population. Okay, as you all know that male more affected than the female. It is both in all the age group, the bimodal distribution. In their patients, high energy velocity, road traffic accidents, okay, fall from height. Elderly people, the older patients, low energy, slip and fall, okay, twist injury to the leg. Anatomical location, proximal third tibia fractures according to 5 to 10% of all the tibial shaft fractures. This is anatomy of the leg showing the lower end of that is the knee joint, the upper end of the tibia, proximal tibia, we call it as tibial plateau, then the shaft of the tibia, then the lower end of the distal tibia, we call it as plafon, okay? Then the lateral malleoli, medial malleoli, then the fibula, fibula shaft, okay? And then the foot, which means the tarsus, metatarsals, and phalanges. What are the muscles of the leg? Okay, we have been taught the muscles. The tibia is the most superficial bone in the anterior aspect. We have the skin and the soft deep fascia in the anteromedial aspect. But in the anterolateral, posterior, and lateral aspects, we have very good muscle cover. Okay. In the first picture, you can see the tibialis anterior. It comes from anterolateral to the anterior aspect. Then fibularis longus, extensor digitorum longus, then fibularis brevis, extensor hallucis longus, then fibularis tertius, and inferior extensor retinaculum. You can see the inferior. It all goes underneath the superior extensor retinaculum and the inferior extensor retinaculum. Okay. When you see in the posterior aspect, posterior, these are all and lateral aspect and anterior aspect. In the posterior aspect, we have two compartments. One is a superficial compartment, another is the deep compartment. What are the muscles of the superficial compartment? Gastrocnemius, we know it's the medial head and the lateral head. Okay. The plantaris, the soleus, which forms tendo Achilles, and the calcaneum. Okay, these are the superficial group of muscles. And the deep muscles of the leg is the popliteus, soleus, fibularis longus, tibialis posterior, flexor digitorum longus, flexor hallucis longus, and fibularis brevis. These are the deep compartment, okay, posterior aspect. These are the compartments of the leg, as I already told you, anterior or extensor compartment, posterior or the flexor compartment, which is divided into superficial deep, lateral compartment. Okay, we all know that lateral compartment is the peroneus brevis and peroneus longus. Anterior compartment, tibialis anterior, then extensor hallucis longus, extensor digitorum longus. Okay, then come to the posterior compartment, tibialis posterior, then flexor digitorum longus, flexor hallucis longus, then medial lateral gastrocnemius. Superficial and deep. Why we have to know the compartments of the leg? In comminuted fractures, where there is shattered more than one piece, sorry, two pieces and three pieces in the bone, the hematoma which is found would be dissipated in the muscles plane, forming the compartment syndrome. We should know which compartment the hematoma is things, and then we have to do a facial thing to prevent the compartment syndrome. So for that, we should not have a knowledge of compartments. Okay, we know now till now we know the anatomy of the tibia and fibula and the muscles, the compartments being formed in around the tibia, and what is the mode of injury? The mode of injury for the younger generation and for the older generation, and for older patients and for the younger patients. The mechanism of injury is a low energy, usually for the older patients. Results of indirect or torsion injury, as I told you, is a twist injury to the legs, leads to spiral fracture pattern with the fibula fracture at a different level. Okay, it usually associated with posterior malleolus with the spiral distal tibia fracture. More likely to be associated with a low degree of soft tissue injury. Okay, high energy fractures. It should be a fall from height, athletics. It's just a direct force, direct fluid wedge or short oblique fracture that may have significant combination with the fibula fracture at the same level. More likely to be associated with a single soft tissue because it's a direct, so it is associated with a soft tissue injury. So how to classify? Proximal tibia, that is a tibial plateau. We call it as a tibial plateau. Normally, there are so many classifications, column, concept, then classification, pools, moves classification. For an undergraduate, chart step, which is the gold standard classification, is still followed. Short-skirts classification. Okay. And based on the pattern of the fracture, we classify the fractures. Distal tibia, that is near the ankle and the platform. Ankle fractures, particularly coming to the ankle fractures, we classify based on the large Hansen's classification. Okay. So upper third, middle third, and the distal third. See, this is the proximal tibia because the tibial plateau fracture. You can see a diagram. There's 6 pictures of the tibial plateau and a line depicting the fracture line. First, in the type 1, there is a fibular head and the proximal tibia. Fibular head, the tibial condyle by the side is called as lateral tibial condyle. So it is a lateral tibial condyle. You can see a fracture line running from the articular surface up to the tibial condyle. It is lateral tibial. It is undisplaced, a single fracture line. We call it as just a split. Okay, just a split. So if you want to describe this, a cleavage fracture of the lateral tibial. So it's called type 1. Type 2, so the second picture you can see, there's a depression of the articular surface of the lateral condyle with a fracture line. It is a little bit displaced. Okay, so in addition to the fracture line, there is a depression of the lateral tibial condyle. So a type 1 fracture with a depressed condyle is type 2. In the third picture, you can work out there is only depression of the lateral tibial condyle. There is no fracture fully communicating to the lateral condyle. See that there is a depression, a huge depression of lateral tibial condyle. In the fourth picture, you can see the fracture line starts from the lateral condyle, it goes to the medial condyle. Okay, it is with a tibial spine involvement. That is medial tibial plateau fracture with or without depression. Okay, medial tibial plateau with or without depression of the articular surface. We call it as the fourth type. We coming to the fifth type. Separately, the medial column is fractured. Separately, the lateral column is fractured. Bicondylar fracture. Okay, bicondylar. If the fracture line communicates with the shaft, that is diaphyseal extension, metaphyseal extension, that's the worst scenario, most complicated fracture. We call it as bicondylar with metaphyseal diaphyseal dissociation. Dissociation of the tibia from the metaphysis of the diaphysis. I repeat, Shaskar types has 6 classification, 6 types. Type 1 is undisplaced lateral condyle fracture. Okay. Type 2 is type 1, that is undisplaced lateral condyle fracture with a depression of the lateral condyle. Type 3 is pure depression of the lateral condyle. Type 4 is medial condyle fracture. Type 5 is bicondylar fracture. Type 6 is with the metaphyseal and diaphyseal extension. So based on the pattern I told you, the shaft. See, in the first picture, the fibula, in the tibia and fibula, there is a horizontal fracture line. We call it as transverse fracture. For a fracture to occur like this, you need a direct impact or a bending force. Next picture, you can see the fracture line is oblique, slanting. Okay? Slanting. If the fracture line runs in one plane only. Okay? So it is called as oblique fracture. Oblique fracture. It needs a bending force. It doesn't need a twisting. Okay? A spiral fracture is one. The fracture pattern runs in 2 planes. Okay? In 2 planes. So anteroposterior, it will be starting from the superior to the inferior, and it goes medially and laterally in a different direction. So it will be like a spiral. So we call it as a spiral fracture. To get a spiral fracture, we need a twisting. And we know that comminuted fracture is more than one fragment. Okay? We call it as a comminuted fracture. Okay? So based on the fracture pattern, we are classifying. Another thing, these are all for closed fractures. The fracture ends of the bone are not seen outside the skin. If there is a wound, and through that the bones of the fracture ends are put in outside, we call it as a compound fracture. So we should have a classification for the compound fracture also. There is a Castillo-Anderson classification. Type 1, type 2, type 3. Type 3 is classified into A, B, and C. Okay. It comes to the type 1. This based upon the size of the wound. Size of the wound. Type 1 is a punctured wound. That is a sharp edge of the wound has come, pierced the skin outside and then went inside. Puncture wound less than 1 centimeter. And then there is not much of contamination. Contamination means from the road, mud, grease, grass. Okay. These are called as contamination. Okay. Minimal contamination and minimal soft tissue damage. Soft tissue here we consider the skin, then deep fascia, then the periosteum. Okay. If you are not able to cover the wound, then it's a maximum soft tissue damage. Here minimal soft tissue damage so that you can suture the edges of the wound. Okay, we call it as type 1. Type 2. The lacerated wound is more than 1 centimeter but less than 10 centimeters. Okay, so the wound is less than 10 centimeter, moderate soft tissue damage, adequate bone cover. You are able to close with a little bit of tension. That is adequate, you are able to do it. Okay, minimal contamination. That is minimal contamination. We pile up all those things in type 2. So the wound should be more than 1 to 10 centimeters, moderate, and then adequate bone cover should be there, and minimal contamination. Type 3, the wound may be of any size, more than 10 centimeters. Okay. The extensive soft tissue damage means the skin, the deep fascia, everything is torn, and you can see the open bone without any cover. Adequate bone coverage. But when you thoroughly debriding, and then you can, if you can do the coverage to the bone, wound cover, the skin cover, it comes at a 3A. Okay. And then based upon the fracture pattern, segmental, severely comminuted fracture, or heavily contaminated, it all comes under 3A. Okay, what will be 3B? The periosteal stripping is there, then we call it as 3B. Okay, all this criteria of 3A, there is heavy means what? Periosteal stripping. The bone covering the periosteum is also torn. Then the blood supply to the bone is hampered. So, which is somewhat immediate action to be taken, intervention to be needed, and the prognosis also to be guarded. So, it comes under classification 3B. And 3C, any open fracture with vascular injury that occurs, vascular injury, the fracture may be of any pattern, but if it is a vascular injury, we type it into 3C. So type 1, type 2, type 3. Type 1 is less than 1 centimeter of wound, okay, and the contamination is minimum, and soft tissue damage is also minimum. Here, periosteum is not torn that much, is intact. Not intact is there. Type 2 means laceration wound less than 10 centimeters and moderate soft tissue damage, adequate bone cover with a group, and minimal contamination. 3 is divided into 3A, 3B, and 3C. 3A is laceration more than 10 centimeters, and periosteal stripping is the excessive soft tissue damage is there, and then heavily contaminations. If there is periosteal stripping also excessive, then we call it as 3B. All vascular injuries is given to type 3C. And here, coming to this is for the open wounds, and for the distal tibia, is AO classification. 42, okay, is the number for the tibia. 42A is simple fracture, 42B is ridge fracture, 42C is complex fracture. Okay. 42A, it is divided into A1, A2, A3, all B1, B2, B3, C1, C2, C3. A1 is spiral fracture, A2 is oblique fracture, and A3 is transverse. Okay. So A23 is transverse, A21 is spiral, like that. When it comes to wedge, okay, spiral wedge, bending wedge, and fragmented wedge. Coming to complex, is C1, C2, C3, spiral, segmental, irregular, whatever we want. Okay. This is a clinical presentation. The picture showing that there is an open wound of 1 centimeter through which the hematoma, the blood is being oozing out. You can see the skin. It is discolored. It is the hematoma, which forms the color. Black is discoloration. You can see the limb is fully swollen, contused, swollen. In this thing, what are the first thing you should check for the distal pulse from the nerve? So the orthopedic examination never ends without the pulse and the neurology. So if it's a vascular injury, you are suspecting the pulse is not felt, then you take a Doppler probe and Doppler, ultrasound Doppler, okay, and check for the vascular arterial Doppler. If even then you are not able to pick up, we classify into grade 3. Even though the size of the wound is 1 centimeter, it won't come under type 1. Because the vascular injury is there. So we go for type 3 Gustula Anderson. Okay. So, okay, what are the treatment for closed fractures and for open fractures? We come to the closed fractures. First, tibial shaft. Closed fraction, cast or slab application. What will be cast? When the plaster of Paris, okay, is throughout the circumference of the limb, round around throughout the circumference of the limb, we call it as a cast. Okay. Day 1 in tibia cast we normally avoid because of the compartment syndrome. But slab, here one aspect of the limb is supported by the plaster of Paris. The other aspect of the limb are wound around by the padded bandage to accommodate the swelling. If it is the hematoma is going to the size of the swelling is going to increase, it has to accommodate. Okay, if you have a tight bandage or tight cast, it won't allow the expand the soft tissues, you definitely go for components. What are the indications? It will be a closed, low energy fracture, undisplaced or acceptable alignment. Okay, it should be less than 5 degrees of varus valgus angulation, less than 10 degrees of anterior posterior angulation. So 5, 10, remember that. Varus valgus less than 5, anterior posterior less than 10. Okay, if it is fulfilling this criteria, go for a slab. Or slab will be above knee plaster of Paris. See that in this picture, you can see more than 10 centimeter wound is there, and the fractured tibia the long spike, sharp spike is seen outside. See that the muscles of the posterior compartment and the medial compartment, sorry, posterior compartment is very well seen, and the contamination, minimal contamination. So will it be a plaster or a POP for this type of fractures? No. We have to thoroughly debride it, adequately wash, remove the contamination, make sure that the tissues are viable, then we go for a wound cover first and the stabilization of the wound externally. Okay. See that here indications of compound fracture, operative, unacceptable alignment, segmental fracture, commuter fractures. Commuter means more than two pieces in a fracture area. We call it as a commuter fracture. Segment means one segment of the bone, there is one above, one below, that is also fracture. It's called segmental. Unacceptable alignment, as I told you, if the varus valgus is more than 5 degrees and anteroposterior more than 10 degrees, then you go for surgery. There are so many operative modalities. Here in this picture, you can see one nail being in the medullary canal, and then it is stabilized to the bone with the interlocking screws. We call it as interlocking screws. This nail is called as intramedullary nail with the interlocking screws. The interlocking screws for the rotational stability. And the rotational stability. This is the proximal tibia, okay, where they have been stabilized the fracture with their one plate from the lateral aspect, and the plate being fixed to the bone by multiple screws. So use of plating in proximal and distal tibial fractures. And this is in the compound wounds where there is, you cannot put a plate or a nail in the day one in a compound fracture where the contamination, we are not sure about the debridement, we go for external fixator. We are stabilizing the bone from externally. So we call it as external fixator. See, there in the first picture, you can see round circular rings being fixed to the bone by means of pins and K wires, and the circular rings are being stabilized connected by one rod. This is called Elizaro circular ring fixator. We call it as Elizaro ring fixator. Okay? It's called Elizaro ring fixator. The advantage is that it has a multiplanar stabilization of the bone. See that the pin of the K or the Elizaro wire pierces one aspect of the limb, that is middle aspect, and then it comes out of the lateral aspect. Okay, that pin, that Elizaro wire is being stabilized to the ring with nuts and bolts. Okay, so that a ring has at least three or four Elizaro wires that being connected to the Elizaro ring. So multiplanar stabilization, and these wires are all tensioned. The Elizaro wires are tensioned. Okay, and this connecting this Elizaro rings are being connected by the connecting rods. The beauty of this Elizaro is that once you have done the construct, you can allow the patient to wait there for the day one. That's the beauty of this Elizaro. And you can see in the fourth picture, the pin being inserted via the skin to the bone and being connected by the universal rods. Okay, the pin to the rod is by the AO connecting clamp. We call it as uniplanar external fixator. It has a stabilization in only one plane. Only one plane. So it's called as uniplanar stabilizer. These are all primary stabilizers. Okay. Then coming to the ankle fracture. We all know the ankle is comprised of three bones. The lower end of tibia, which is medial malleus, the lower end of fibula, which is the lateral malleolus, and the talus, okay, and the tibial place. Okay. So ankle comprises of tibia, fibula, and the talus. The talus articulates with the tibial platform superiorly, as I already told you, posteriorly with the posterior malleolus, with the tibia, and medially by the medial malleolus, laterally by the lateral malleolus of the fibula. There is a picture showing the distal tibia, the medial malleolus, the talus, the fibula, and the lateral malleolus. Okay, the ankle joint is the only joint, the leg, which is not covered by much of the muscles and the distinct muscles. We don't have a tough muscles around the joint. Only the ligaments and the tendons which passes anterior and posterior to this joint take care of the stability of the joint. Mainly the ligaments. Ankle joint is is, uh, is mainly stabilized by the ligaments. This is the picture. You can see the lateral ligament complex. This is a fibula, lateral end, lateral the distal fibula is called the lateral malleoli, and you can see the talus bone there and the calcaneal bone. So you can see posterior talofibular ligament. From the fibula, it goes to the talus. So in the posterior aspect, it's called posterior talofibular ligament. So in the anterior aspect, anterior talofibular ligament. Okay. And one is being fixed to the calcaneum, we call it as calcaneofibular. So anterior, posterior, and inferior, it's all stabilized with these three ligaments. The joint is supported by the fibrous capsule, as I already told you, it surrounds the joint and is attached all around the articular margins. Lateral ligaments, anterior tibiofibular, calcaneofibular, and the posterior talofibular. This one I already told. And the medial aspect, we have the deltoid, medial deltoid. We have the superficial and the deep deltoid ligaments. They are very strong triangular ligament present on the medial side. Okay, that is tibiocalcaneal, tibionavicular, okay, and posterior tibiotala and anterior tibiotala. What is the mechanism of fracture? This ankle fracture we classify based on the large Hansen classification, which mainly takes into account the position of the foot and the force which causes this injury. Okay, these two things takes it into account by the large Hansens. Okay, here the mechanism of injuries fall from the height, direct force or trauma, a twist injury to the foot. As I told you, large Hansen classification based on the mechanism of injury, supination, inversion, we will have the medial malleolus, oblique fracture, and a horizontal fracture of the lateral malleolus. Okay. Supination, external rotation. It is above the border. Pronation, reversion. The fibula, that is lateral malleolus fracture above the supraspinatus level, and the tilops, that is the anterolateral fragment. And supination, plantar flexion. We will have the fibula, lateral malleolus at the level of syndesmos. This is enough for the UG level. If you go for a postgraduate level, you will go in detail. Okay. Clinical presentation, you can see there is a bony prominent of the middle malleolus. You can see the ecchymosis, that is the ramification fracture. Okay, the tense swelling there, the posterior to the middle malleolus, swollen foot. So swelling, pain, tenderness, ecchymosis of the deform. What are the investigations we have to take for? We have to take ankle X-ray, AP, and lateral view, SMF. If needed, mortism. Okay. AP view, lateral view, if needed, mortism. CT scan in need of in terms of intra-articular pylon fractures, comminution. If it is beyond our diagnosis of the X-ray, we will go for CT scan. Treatment, non-operative. If it is undisplaced fracture, we go for non-operative treatment in the form of plasters, slab, or cast. Okay. Isolated lateral malleolar fracture with less than 3 mm displacement or no tubular shift. Posterior malleolar fracture is less than 25% of the joint involvement, less than 2 mm step off the articular things. We can go for a consideration. So these are the indications of a non-operative treatment for isolated fractures, less than 3 mm displacements, and posterior articular means posterior, and this thing malleolar fracture is less than 25 mm percentage of joint involvement and less than 2 mm step off. So this is a picture of a well padded cast, below knee cast. Usually we apply for ankle fractures and distal tibia fractures. Operating, yeah, basically we all know that it's a comminuted displaced bimalleolar, okay, posterior malleolar fracture more than 25% and more than 2 mm of step of an articular surface, the open malleolar fracture, talus displacement is there. Okay, any non-union or a delayed union, you go for an operative treatment. I repeat, there should be bimolar fracture with the talus displacement, isolated fractures is displaced, bimalleolar or trimalleolar fracture, posterior malleolar fracture is more than 2 mm step off, and delayed union or non-union. Operative modalities, we go for open flexion and joint fixation. The fixation methodology, implants used may be anything. You can put screws, you can as malleolar screws, or a tension band wiring, plating, based upon the fracture pattern, you can decide. So this is the X-ray showing in the left side, showing that two screws, one from the tip of the medial malleus going to the shaft, okay, another from the anterolateral aspect of the fixing, anterolateral aspect of the fixing, okay, and one cannulated cancer screw intramedullary for the lateral malleus, okay, intramedullary. So just a screw fixation. The other thing you can see in the lateral malleus in the right side, we had a nice plate and the screws of the fibula plating, two screws which passes the fibula and then is fixing on the tibia also. We call it as syndesmotic screws. Call it as syndesmotic screws to stabilize the syndesmotic joint. Ultimately, after stabilization, we will see the ankle mortise. See that the talus is being well placed in the ankle mortise. The distance between the medial malleoli and the medial surface of the talus and the lateral malleoli and the lateral surface of the talus. We call it as the joint space. If any one of these things is low, it is pushed away from this. Okay? Then your joint is widened. The ankle joint is widened. The syndesmotic joint is not working. The syndesmotic joint is not working. In that place, we have to stabilize the syndesmotic joint with the help of this syndesmotic screw. Syndesmotic screws. Nowadays, we have suture anchors for syndesmotics. So the problem with the syndesmotic screw is that once the syndesmotic screw, that is a syndesmotic joint or the fracture heals, we have to remove the screws before doing that. Otherwise, the screw will go breakage. But it is not in the case of suture anchors where you can allow weight bear after once the fracture heals, you need not remove any implant. The suture anchors is giving weight, is tensile strength will allow you to weight back. So nowadays people are using, the surgeons are using suture anchors over this suture means what? Syndesmotic screws. So we have seen today the tibial fractures starting from the proximal tibia, the middle third, there is the shaft of tibial fracture, then distal tibia fracture, and the ankle fractures. So in proximal tibia fracture, that is the tibial platform, I will show you what I'm going to tell you. See here, proximal tibia, that is tibial plateau fractures. In tibial plateau fractures, we usually use plating. Plating, cancellous screws. Okay, nailing is very difficult, but nowadays we have a universal nail. We call it as a universal nail because the nail has to be then put into the tibia, that is in the medullary canal of the tibia. The entry point is just above the tibial tuberosity, okay, in the intra-articular area. That is the entry point for all tibia nail. It is called expert tibia nail. To fix the fracture fragments of the proximal tibia. It's difficult. Okay, the entry point is difficult. For that, we usually go with the plating. We open the fracture site, reduce the fracture, temporarily stabilize with KOS, and final construct we fix with these plates and screws. That is stabler in proximal tibia. That is tibial tibial plateau fractures. Here, there is a lateral locking plate. We call it as a lateral locking plate, single plate, only on the lateral aspect of the tibia, stabilizing the fracture. If you need in the posterior aspect, we go for a posteromedial plating, posterolateral plating, and then medial plating. So Column concept. What are the columns? When you see the proximal tibia, we divide into four columns: anteromedial, anterolateral, posteromedial, and posterolateral columns. Based on the mode of injury, you will get the combination of the these columns, anterolateral with posteromedial. Okay, all columns are involved. Like that, based upon the mode of injury, you will get this one. So there, for each and every column should be addressed. You can't just like that posterolateral. It's very difficult to assess. And then the common perennial nerve comes there. So I will leave that only stabilize this lateral and the posteromedial. I won't address the posterolateral. If you do like that, the problem is the extreme flexion that needs the posterior corner, posterolateral, posteromedial corner has to be stabilized. In that condition, your treatment has some lack. You can't give a full range of movements for the patient. So in proximal tibia, column-based concept, column concept. Okay? You have to reduce all the columns, address the columns. If your skin, the swelling of the compartment, the swelling of the proximal muscles, the hematoма, is not allowing you to open and then stabilize it. Minimally, you reduce it with K wires or screws. Okay, you have to address it. And then one final construct, for example, lateral one plating, posteromedially, minimally open, reduce it, and then put K wires or CC screws, means cannulated cancer screws. Okay, just to prevent the uh, slipping of the posteromedial fragment. Okay, and see for the medial fragment, but also stabilize with multiple screws if your soft tissue is not allowing to open and stabilize it. Okay, so in proximal tibia, we have to stabilize the fractures of all the columns with plates and screws or whichever the thing we may available. We should not disturb the biology much. So we can go for Elizero also for the proximal tibia. We can go Elizero for the shaft. Okay, that works very well for that. Because for shaft tibia fractures, if it's a close, we go for nailing. As I already showed you, this is the shaft fracture of the tibia. We can go for intramedullary interlocking nailing. Okay, this is for the compound fractures. And for the ankle fractures, you can choose any modalities like these. Okay. So we have a very good holistic approach for the tibial fractures. Thank you. Dr. Hari.